Yay, there he is.
Oh, that would caught us a little by surprise.
Oh yeah, that's all right.
All right, we'll see how many guys we get at 4 p.m. Hawaii Standard Time. I know we got a lot of people waiting for Dr. Kim. See here, yep, boom, there they coming on. What's up, guys? Aloha Tuesday. Aloha Tuesday, special edition with a very, very special guest. So, whew, hot, man. Came straight from work, put on the AC. So the AC is not never gonna take a while for this AC get cool. So it's a little warm in here, bro.
I can tell, bro, because I I'm in the same predicament as you.
Oh, what's up? What's up? How you guys? Welcome, welcome, welcome. I know it's early. I know it's early. I know a lot of you guys are working. A lot of you guys are not used to coming on so early, but as you know, Dr. Jerome Kim is a very busy and sought after speaker and expert. So we had to adjust our time to accommodate his schedule. So that is what we're going to see tonight. And I don't know how many of you saw his segment. I posted it on Asian Boss. It's a podcast that is quite popular. And he was on last week. And we're going to try and see if we can get him to share what he shared on Asian Boss, as well as give us his insights as far as the direction that Hawaii has taken as it relates to safe travels and lifting up restrictions. We haven't had the discussion, but I'm curious to see what Dr. Kim will say, Charlie. I'm really interested in
Yeah.
hearing. You know, Dr. Kim is not a politician. He doesn't he doesn't do things for votes. He's a scientist. He's the director general of the International Vaccine Institute. Only relies on science and data. And this is what we try to bring you guys. And then again, like Charlie always says, you take it for what it's worth. And we'll see what he has to say tonight. I'm excited, and he should be on very, very shortly. So
Well, brother, I just want to tell you it's good to be back on a different night. I had to
yeah.
remind myself we're on Tuesday for tonight. So a question was posed: will we be on tomorrow night since we actually are on one day late for Monday, but one day early for Wednesday, or are we going to do a back to back, or just wait till Friday? But what is it going to be?
Up to you, Charles. Up to you, man.
I don't know. After tonight, I think we gotta let everything digest for a while, especially with this power hitting guest, like just like when we had Murtaza on. I mean, very powerful hitting, and
Yeah. We'll let
so
you guys know after tonight's show. Charlie and I will have our discussion and then figure out what we'll do. Um, uh,
but
yeah.
what I wanted to say really quickly was there is so much confusion, and yes, please share, everybody share whenever you can. But I know there's been a lot of confusion right now in the state of Hawaii because it seems like what is being done now, and I don't believe it has anything to do with the vaccines because I cannot believe we're at that point. And I tell you the truth, I've been working down by the hotels these last couple of days, and it seems as if some people are very open about not using a mask anymore. So I don't know if it's a mask thing or it's a vaccination thing, but I think people are just visitors alike and some locals. They are just going for broke. That's all I can say.
Oh
They're
yeah.
just going for broke as if no biggie. But there is a variant now that has come on the scene, and I forget which and it was. But it seems like the thing, that variant is just not afraid of vaccines. It's moving at a quick pace. That's what I wanted to ask Dr. Kim tonight about the variants and how much of a role it plays. How much of a role it plays.
He is in the waiting room, so we're gonna go ahead and bring him in, guys. Right now, share,
Yes.
share,
Yes.
share, share,
Share, share, share.
share, share, share. All right, here we go. All the way from South Korea.
Yes, yes, yes. And he's connected. And there he is, the one and only. I just love that backdrop, boy. Woo. Aloha, Dr. Kim.
Hey, Charlie, how are you?
I'm doing fine. I'm
You
doing
know,
fine.
this
Thank
from
you.
Liberty House.
From Liberty House.
That's how
That's
long ago.
beautiful. Yes, it's beautiful. It's beautiful.
How are you, Dr. Kim? Aloha and welcome back to our show.
Hey, Mel, how are you doing?
Doing well, actually, doing really well. We're looking forward for today. I know we got a bunch of people that are kind of bummed because it's too early here in Hawaii, but they'll get to watch the replay. We have a 52 people so far, and
Great.
all I know is that a lot of people are very excited to have you back on and to hear you. A bunch of them did watch your segment on Asian Boss. And for those of you that don't know, Dr. Kim, Hawaii's own, now residing in South Korea as the Director General of the International Vaccine Institute. And he has been gracious for his love for Hawaii has brought him on our show. I think it's the third time now. So
It is.
we truly
Yeah.
appreciate. I know you're a busy guy, all over CNNs and all kinds of different Zoom briefings and meetings. So we appreciate you taking the time to be with us today. I know that you do follow what's going on in Hawaii because your family is here in Hawaii, your parents are here in Hawaii, and you'll be coming back soon, right?
I hope so. In less than a week. First time in 2
Yeah.
years.
Yeah,
Wow.
gosh, I cannot wait for the day my wife and I get to jump on a plane. And not that we can't do it right now, we're still a little cautious, so we're gonna wait a little while longer. But to go visit our kids and my dad and up there in Washington and Oregon. So I'm happy for you. I hope you get to make it back and come back home for a little while.
Yeah, looking forward to it.
Yeah, that's good. So I like the tie, by the way. I like the tie. It's nice. As I mentioned, Asian Boss, you want to try and cram as much of that information in to our viewers here that may not have seen that, and then also spend some time to talk about what's going on here in Hawaii as it relates to the travel program and the restrictions. As you know, we're at 52% population vaccination. That's the average. I mean, that's not saying every island is 50% or every community is 50%, but statewide 52% total vaccination. So we do want to spend some time with that. But I guess let's just start out with giving us an update of what you know as far as the vaccine throughout the country, throughout the world. What's the climate like in Korea? I know Japan is seeing some spikes as well. But what's your take on what's going on right now?
Yeah, the world is kind of a confusing place right now because you're looking at some countries like the UK and Israel and actually in the United States where the number of infections has been decreasing significantly. And in Europe, again, whether it's due to vaccination or some of the other things that countries have done, the rates of infection appear to be decreasing. What's odd is that there are some countries, the ones that have done well in Asia have had recent spikes. Taiwan, Thailand, Japan, although they've come back down again also. And it's been a bit confusing because some of these Asian countries haven't been as aggressive at pursuing getting vaccine. In Korea, it's about 14 or 15% of people have received at least one dose. And in part, it's, more people would get doses. It's been, the country has not taken its time, but it's been the shipment of vaccines to Korea has been slow. And so, we've still been able to keep between, I guess, 300 and 700 infections a day. And it's been like this for about 3 months. So in Seoul, we're on what we call level 2, which means you can't meet it in a group of more than 4, except unless you're family, in which case you can meet in a group of 8. And you can go to restaurants. Restaurants are open till 10. They're spaced. And actually, we were at a restaurant with 2 other friends, my wife and I. And this guy throws the window open because they're supposed to ventilate periodically. So he did. He opened the windows and then closed them again. But the people are trying. And if you go out on the streets, everyone's wearing a mask. But still, we're having these infections and large outbreaks, and they're happening whenever the masks come off. And that's it. That is, like, you're in your group of 4 friends, or you go to a karaoke place, or you go to church, or you go to a bar in the basement of a hotel that, where 200 people got infected. So, it's been difficult to keep this level of infection. I mean, I think Korea is still ranked in the top 5 places to be during the COVID pandemic. But it's, people are getting tired, and that's when you stop paying attention and when you stop being completely on top of it, that something happens. Like in Taiwan, they weren't wearing masks. They weren't necessarily even checking people who came in with fever to emergency rooms for COVID. And that's how an outbreak starts. So even though vaccines are out there, even though the official CDC guidance is, if you're vaccinated, you don't need to wear a mask. There are going to be people who need to be careful. And when I go to the United States, and we're going to, as much as possible, try to be careful. Even though we're vaccinated, we got my wife and I both got the Johnson & Johnson vaccine courtesy of the military. But it doesn't stop you from, it doesn't stop me here from wearing a mask. In fact, at work, completely discourage face-to-face meetings. But if it has to happen, then we try to separate as much as possible, and we wear a mask.
Well, let me, we had a recent guest of ours that's been before, and like you, he's noted in the CNN and MSNBC world, Dr. Murtaza Akhtar, and he's kind of relocated now down to Florida. And he did mention that at one time, Florida was the total anti-mask, anti-this, anti-state. But once the vaccine got there, you would think everybody would just throw the mask away because they're already anti from the beginning. But it had the opposite effect, you said, that everybody started to wear their masks. There's more mask usage now than there were before, and they got vaccinated.
That's incredible. And, it's really, it's hard to explain what things influence mask use, but, maybe when they go to get their vaccine, the person who's vaccinated them reminds them, you're doing this because the vaccines, they're really good. The Pfizer vaccine, the Moderna vaccine, which are the ones primarily used in the US, they're 94, 95% efficacious. When we're looking at effectiveness now, when we vaccinate large numbers of people, effectiveness in reducing severe infection, disease, hospitalization, death is also in the 90s, and it's in the high 80s, even in the presence of mutants. So, these things are really great, and it's good that people are wearing masks because, what we do know about these vaccines is they don't necessarily always prevent infection. So they're really good at preventing manifestations of disease, and they're really, really good at preventing hospitalization and death. 90 to 100%. It's really great, but you can still get infected, and that means you can still spread it. And the mask, it does protect you, but it really does a good job in protecting other people from you in case you have acquired the infection. So again, it's important to remember that we're wearing the masks to protect people who aren't vaccinated. And it's really critical that we continue to emphasize the message. Now, the official guidance is once you're wearing a mask, once you're vaccinated, mask comes off, and several states are opening up. Again, it's just important to remember that the US system is an honor system, right? You're trusting that the person out there without a mask is vaccinated, and we can't always be certain of that.
Yeah, I think
how is
that's a huge discussion for quite a while now about can vaccinated people still catch the virus? Well, we know that to be true because we've seen the cases of that, and there are many, especially here in Hawaii, some of our leaders that are trying to convince people that once you're 14 days after your second shot or your first shot, if you're a J&J, that you're totally immune and that you're safe and you cannot spread the virus. But you know, all that I've read and watched on YouTube on experts like yourself, I'm hearing that it's still possible and that we just really don't know the extent of the ability to spread this virus, even if you're vaccinated.
Yeah, and it's really, you know, I mean, we can talk in theory, and then we can talk with actual data. You know, in theory, a vaccine that prevents actual infection, so you know, you get exposed to the virus and you don't get infected, clearly you're not going to spread it if you can't be infected. In theory. The other part is, again, in theory, when you get the Pfizer vaccine, and this is the only vaccine for which you really have data, if you get the Pfizer vaccine and you get infected and you actually come down with an infection, then the amount of virus that's in your nose and throat is significantly decreased. And that, in theory, should decrease transmission. Does it reduce the risk to zero? Probably not. So again, the mask is important because it keeps you from potentially infecting other people. How good is Pfizer at preventing infection? So Pfizer is probably 60% efficacious in terms of preventing infection itself, which is great. The other vaccines are less good. With AstraZeneca, it was 45%. With some of the other vaccines, it's 50%. So, you know, but they're really, really good at preventing severe disease, which is what you want. You know, you don't want people in the hospital. You don't want people dying or on ventilators.
now, Doc, with regards to the variants, you know, the talk has been, and we've been following it quite frequently. We talk about the California variants, the two of them, right? The 439 or the 427, whatever the numbers are. Then you got Brazilian, you got the UK, and the South African. Is there anything, the Delta variant, what is that? Is that something that just arrived on scene recently?
So in order to avoid labeling places, the World Health Organization designated viruses by Greek letter. And Delta is the designation given to the viruses that have come out of India. So that's B.1.617 and -2, and so that's the Delta virus. And so the Indian variant is kind of interesting because it appears to be more transmissible, like the UK variant was also, and in some cases. So when we're looking at the protection that vaccines give against the original Wuhan virus, right? We call it the prototype virus, and then the virus that kind of took over in Europe and the US in the spring of last year, the vaccine worked. The vaccines were tested against that strain, and it looks, you know, the vaccine, you know, we know the data, right? 94.5%, 95%, you know, lots of good activity, 78% for Johnson and Johnson. For efficacy, only Johnson and Johnson and Novavax, which isn't yet approved, have actually been tested against the South African variant. Actually, have phase 3 test results, and it looks like the efficacy drops against the South African variant, which is what you'd expect because these variants. If you remember the model of the virus with the spikes protruding from the outside, that spike protein is slightly different, so that the protective responses generated by the vaccine don't bind as well to those spikes, and that causes a decrease in the ability of the vaccine to protect you. So that's in theory, right? That's testing in these phase 3 trials. Then we can also take blood from people who've been vaccinated and check to see whether that blood will neutralize the viruses in a test tube. And so far, for all the virus vaccines tested, if you take blood out, you do see some level of protection against, or some level of neutralization, that is inactivation, I guess, of the virus in a test tube. And that's kind of, until recently, as good as we could say. We could say, well, it should protect you in theory, right? Now we're starting to see effectiveness data against the mutants. And so what do we mean by that? So in Israel, they vaccinated now over 90% have received 1 dose. And they're beginning to be able to tell when the vaccines are protecting against variants from the UK or variants from India or variants from South Africa. And with all this collected data now, we have some actual effectiveness data on this. And, you know, effectiveness is still pretty high, but it tends to drop with certain of the variants. And so again, and what's really clear is that in the setting of variants, you really do need 2 doses. So people out there who've only got 1 dose and figure, I should be okay because a single dose protects, you need to have that second dose in order to really have good protection against variants.
Okay.
Doc, and you talked about this on Asian Boss about natural immunity versus vaccine immunity, and without getting too technical, what's the difference? And should people that have had COVID be vaccinated as well?
Yeah, and so the official answer is yes. And you know, whether you need a single dose or 2 doses of the vaccine is not really well defined yet. But what we do know is that if you've been infected and you get a with your first dose, say a Pfizer, you develop really, really potent protective responses against COVID, to the point where your blood, once you develop the protective responses in the blood, they will neutralize the variants. I mean, and this is in vaccinology, we call it priming and boosting, right? When we give 2 doses, the first dose is the prime, the second dose boosts it. With natural infection, your body is primed. You've been exposed not only to that single spike protein, which is in the vaccine, but you've been exposed to the whole virus, and you've been exposed to a lot of it. So your body's defensive system not only develops these protective immune responses against the spike protein, but it also develops what we call T cell responses. So the immune system has a second component that doesn't only make this infection fighting protein, but has cells. My mom used to call them the soldiers. My mom was an allergy nurse, so she talked about the white corpuscles in those days, what we call white blood cells. But a component of that are called T cells, and the T cells are really interesting because they help the immune system to recognize viruses, and sometimes they make immune responses much, much stronger. And then another component of those T cells attacks and kills cells that are infected with COVID-19. And natural infection does that really, really well. The vaccines tend to focus on one thing. So the Pfizer vaccine does generate some what we call cellular immune response, but what we really see as protective are these antibody responses. With natural infection, you get everything. And it's not only to the spike protein, it's to whatever in the virus looks foreign to the body, because that's what the body does. And, you know, so, and then, you know, some people complain, you know, we're putting something unusual or different into our bodies. Well, imagine if you get infected and you have millions of viral particles in your body, far in excess of what we would give in a, you know, half a cc injection of a vaccine. So again, there is a call for boosting. There are some data that the protective responses to against COVID after natural infection may persist, certainly longer than 6 months. Can you be reinfected after you've been infected once? Absolutely. And it may be that variants, again, have an easier time infecting you. So if you compared vaccination to natural infection, what's the difference? Well, you know, our vaccines have efficacy in the 94, 95% range, the Pfizer Moderna. Natural infection's about 80%. And it can be boosted. So again, as with boosting, we don't know how long that protection will last. I mean, at most, we're out a year for many people.
So if we're talking about that complete protection, what you just mentioned, with vaccination and one's natural immunity, is there a way of measuring? And it sounds like a crazy question, but is there a way of measuring at what level you've built up this resistance to protect oneself, whether you caught COVID or whether you got the shot? Is there a way of quantifying what's in you right now to say, hey, you've got the highest of the highest, of you're right now, you're at the lowest, therefore you need a booster or something, right? Is there a way of quantifying and measuring it?
So that's actually a really, really interesting scientific question. And it's not crazy at all. I mean, it's a question that we're all really eager to know the answer to. And it's something we call a correlative protection. That's the scientific term, is correlative protection. But what it really is exactly what you're describing. It's a lab test that tells us if a person can be protected. And so the way we develop a correlative protection is in one of these big trials, phase 3 trials with 30,000 or 60,000 people. A certain number of people who've been vaccinated are going to get infected. The vast majority of people who are vaccinated are protected. So what you do is you compare this lab test, this lab assay, say it's looking at the antibody that inactivates or neutralizes the virus. You look for the level of that in the people who've been vaccinated who became infected and the people who are vaccinated who are uninfected. And typically, the level is higher in the people who don't become infected. And so what you can do is say, okay, this antibody, this neutralizing antibody is the correlative protection. And then you vaccinate people, then you watch this antibody level drop over time, and finally it becomes undetectable, and you say, well, maybe it's time to start boosting. And if we're really, if the science works out correctly, then we can tell you at a certain level, at a level of 10 or 50, you see protection. And when you drop below it, you start to see infections again. So people need to be vaccinated. But we don't have that yet. We were hoping to have it in March, but now it's June and we still don't have it. And it looks like it's going to be a while. We were on a call with the number of people around the world, and this question came up. And some of the regulatory agencies, so with the US FDA, really weighs in on these questions. Is there a lab test that you can do that tells a vaccine whether it's protecting or not? And it's really important for the FDA, because if they say that, if they say, okay, it's neutralizing antibody, then the vaccine companies will say, great, we don't have to do a study in 30,000 people anymore. We can do a study now in 1,000 people or 2,000 people. We can really speed up. Do you need to get a booster dose at month 6 or month 12? How do the new variant vaccines work? Oh yeah, it looks really great. We're getting lots and lots of this, protection. So this one assay, if we had it, would be a key to much, much better vaccines, much better dosing. I mean, unfortunately, we don't have it yet. So long answer to your question, but it's a really, really important scientific question, because, we did these vaccine trials originally. With vaccine, you either got the vaccine or you got an inactive substance, a placebo. Well, it's now increasingly not considered ethical to give people a placebo, because now there's a vaccine that actually protects. And what you're saying when you give a placebo is, but we're going to give half of you an inactive substance, even though the FDA has given emergency use authorization to the Pfizer vaccine. We think it's safe to give you a placebo, and increasingly that's unacceptable. And so now we really do need this biomarker or correlative protection.
So is it safe to say when someone is given a placebo and it's inactive, it's more like basically tricking the mind, right? Because if you give someone that, they really don't know. They just want to see the response, whether it can be a true response, or, I don't know how you can fake a response, but just a response in general. Yet there was nothing given more than, say, sugar water or whatever,
Yeah. So the reason we do that, it's saltwater injection, is that what one of these phase 3 trials tries to do, and the reason you have 30,000 people, is you're trying to answer a single question: does this vaccine prevent mild PCR positive disease or not? And it can be biased because if we gave everyone vaccine and the doctor saw you getting it and you knew you were getting it, you might not come in if you had if you felt a little rough and you're tired and you had a mild fever, you might not come in. When you're in a clinical trial, we don't want you to be biased, and we don't want the doctor to look at you and say, well, there's probably nothing, we're not going to test you. What the FDA wants is they want to make sure that this is designed like an experiment in the lab. Half the people get one thing, half the people get the other. The patients and the doctors and nurses don't know who got what, so that we don't bias our results by saying, well, I think you got the vaccine, it's not going to bother you, don't worry, don't report the pain in your arm, or don't come in when you have this really severe headache for a week. We want them to come in, we want them to report everything, and we want the doctors and the nurses not to know who got what, so that they don't bias the results because of their prior beliefs. So when you do these experiments, you really are focusing on making the result as clean as possible. And when you have a placebo, you can do it very quickly. If you don't, then you have to compare, vaccine A against vaccine B. So for instance, if you were comparing AstraZeneca to Pfizer, you'd have to enroll, already we were enrolling 30,000. You might have to enroll in making a number of 60 or 80,000 people, because comparing something that is, 60% or actually 76% efficacious to something that's 95% efficacious really is more complicated for us. So we were really lucky in the beginning. We got answers. We got actually a lot of positive answers, but increasingly it's going to become difficult to use that placebo control because people are going to say, well, why? You have vaccines that work. Why am I getting something that doesn't work? And it really is becomes difficult for us now, especially when you look at some of the new vaccines. They're easier to take. They're easier to give. They're not RNA. They're protein. They're the kind of vaccine that we've gotten in the past for hepatitis or other diseases. So it's really an advantage sometimes. These newer, we call them I don't know why they call them wave 1A and wave 1B. Wave 1A and wave 2, but the next set of vaccines that are coming, later this year and early next year, could be improvements on the current vaccines in terms of side effects, in terms of ease of use, in terms of the level of protection and the length, in between shots. So we're hoping for some improvements.
Thank you.
Real quick, Doc, before I ask you my question, there was a question: how long has it been considered unethical, doctor? I want to make sure they understand the unethicalness. How I understood it was the fact that after the vaccinations have been in the field and being administered, that using placebos, maybe you want to just clarify that.
Okay, that's a great question, and it's a complex area, in vaccines in particular. So, sometimes it's important to test vaccines all over the world. And in fact, it's for vaccines that are going to protect everyone. You really want to test the vaccine in different conditions. And why is that? There's a really great vaccine against rotavirus. It's a diarrheal disease that affects kids. And the US has had a vaccine since 2006. It's an oral vaccine. And 3 years or 4 years after we started rotavirus vaccination, then you couldn't find a rotavirus case in the United States. Medical students would have to go outside the United States to see a case of rotavirus diarrhea. That's how good the vaccine is. Wonderful. So we take the vaccine and we go to Africa and we start using the same oral vaccine, and its efficacy is 50% or 40%. And why? It's because it's the oral vaccine. The oral vaccines don't work as well. So does that mean that we're not going to use rotavirus vaccine? No, we have to continue to use it. But it was really important to know that the vaccine doesn't work as well in kids who, because of where they live, have had multiple infections, multiple episodes of diarrhea, or may have malnutrition. And that really impairs their ability to take an oral vaccine. So it is important to test vaccines all over the world. And some people say, it isn't, and again, this gets to some of the medical ethics. if you're going into an area where the vaccine isn't being used at all, so if you've got a new vaccine against pneumonia, for instance, you go into an area where the vaccine isn't being used because it's too expensive, because the country doesn't know that it has a problem with this particular kind of pneumonia. Some people would, and actually many ethical committees consider that ethical then, to test the vaccine to show that it works in a new country that doesn't know that it has a problem. You prove that it works and you convince the country, you've got a problem here. Here are the data. You have a lot of this kind of pneumonia. The vaccine prevents it, and it's very clean. And the country looks at it and says, we agree. Or you take it to the WHO and say, this problem exists all over the world. Here are the data. And then WHO looks at it and says, we agree with you. You need to give it. And it gets to it's a really important question, because the rotavirus vaccine, again, just to come back to that one, we started using it in 2006. The WHO recommended it in 2009. In 2021, 60% of the kids around the world do not get rotavirus vaccine. In the past, it was coming from two major companies. One is GSK, and the other one is Merck. And we just, tried to get other countries to use it. We got it into programs. There's an organization that gets the vaccine and distributes it to the poorest countries in the world. But still, there wasn't enough supply. And it's expensive. In the US, you pay $100 a dose. In Gavi, you're paying $2 a dose. So if you're Merck or GSK, maybe you don't want to make 400 million doses of something. You're going to have to sell for $2 a dose. You rather sell that vaccine for what you can get in the US or in Europe or Canada, Australia, Korea. So some other companies, Indian companies, started to make this vaccine, and they were going to give it for $1 a dose. In order to get that tested, though, it was really difficult for them to do a trial comparing their vaccine to placebo. It had to go through 4 different kinds of ethical review in order to, get the trials approved. Number of different ethical panels reviewed it. So we're in an area where, it's really important. Did it potentially delay the availability of this vaccine that is now available at $1 a dose? Yes, it can and does. So, sometimes in global health, you're saying, well, in order to get it out fastest, we may need to do a placebo-controlled trial. And then you go to ethical committees in the countries where you're doing it, ethical committees in the US or in Europe, and you really kind of get in, we have to conduct research ethically. And that's an absolute requirement everywhere. And so we take these precautions and we listen to the committees of people from the area and pay attention to them.
So Doc, now we have this, I guess, with so much vaccines, or individuals have taken vaccines, that we see a great decline in the amount of those who are getting really sick because of the vaccine. Transmissibility is, again, priority would be aerosolized droplets going out, right? At one time, it was believed that if it drops on surfaces, there's a potential that the virus is still alive on surfaces. Now they kind of scaled back on that, from what I understand. So does it really make a difference on how big the droplets is that's carrying, say, the virus, or potentially more than, or a bunch of viruses in a droplet? I mean, how is it quantified in that respect? If somebody aerosolizes and you catch a blast from them, right? Because it all depends. One makes it into here or on one of your openings and attaches itself down there to start infecting, correct? That's pretty much the process, right?
Yeah. So, again, the question is complicated because it's difficult to estimate, to design an experiment where you actually take people and challenge them with the coronavirus, right? The COVID-19. And if you could, and they're actually now in the UK, in Great Britain, designing experiments where they're doing human challenge with COVID. And it's a
Wow.
problem it is a, I mean, people actually, over 10,000 people in the US volunteered to participate in these experiments also, because they realized that they could have important implications for how we wear masks, how long we wear masks, you know, when surfaces are appropriately decontaminated. But it's a really important question. So it's likely that the coronavirus not only is droplet, but is airborne, right? And so aerosol. And the difference is droplets, and this is really actually based on really, really old work, decades old work, that the droplets tend to fall to the ground within 6 feet, 2 meters. And the aerosols can be carried on air currents quite a distance. And actually, I saw this great presentation by an architect, a professor of architecture, on circulation in buildings. And he looked at all these coronavirus outbreaks in Korea and in China and elsewhere, where depending on where a person was positioned relative to an air conditioner vent, you could see the spread of COVID-19 in a restaurant or in a building. And again, in Hawaii, it's kind of warm all the time, but in places where, like in Korea, where it's cool or warm, air flows differently, either up or down in a building, in the ventilation systems. And that actually can impact the spread of aerosolized particles. So it's a really complicated, it's important that we recognize that that airborne spread is important. Should we give up on hygiene? Like, you know, the hand sanitizer, washing things down? No, but it's probably less important as a mechanism of transmission than direct exposure. As a part of his presentation, he also talked about some of the experimental studies that are done. And it really does turn out that the louder you're speaking and the more air that's coming out of your lungs. So if you're really shouting, you know, face to face and shouting at somebody, you're aerosolizing lots and lots of particles. If you're in a choir and you're singing, you know, the Alleluia chorus, and there's people behind you, all of that air could potentially contain coronavirus. And then, you know, you're taking these deep breaths in when you're singing, and again, that is a problem. For surface transmission, you know, there were some transmission cases in Korea in karaoke bars, not to the person in the room. There was spread, but there was people, because they weren't wiping off the microphones.
Mm.
And some people, I guess, when they're singing, they hold the microphone right up to their mouth, and they might touch. And so we don't know how it happened, whether it was another surface within the room or whether it was, but they changed the rules on decontamination of these karaoke rooms after that happens. In Korea, it's called noraebang. So they, you know, I think it's important. We have learned some things, but yeah, you're absolutely right.
Okay. Thank you.
You know, I'll go back to the vaccine and how long the vaccine works. We really don't know yet. I know originally they talked about, you know, 6 months. We talk about boosters. We don't. Do you know if, in fact, we are prepared to mass boost everyone? And this is why. This would be the segue into a discussion about our Hawaii's direction. We started vaccinating pretty close to 6 months ago, and let's say Hawaii is at 50%, or let's say 60%. The bulk of those that got vaccinated were in the early months of the vaccination. As everybody, the kupuna, all the caregivers, all the front line, all of these people went out. Now, we're setting in Hawaii, we're setting benchmarks based on time or vaccination percentages.
Right.
But there's going to, every day, if let's say the vaccine is good for 6 months or 7 months, or whatever it may be, every day there's going to be a bunch of people that's going to drop that percentage of vaccinated people if in fact that vaccine is no longer working. Do we know how long or when will we find out how long the original vaccines work, and then will we need a booster, and if then, how often? Has that been figured out yet?
So there are now, they're not necessarily published, but there are data out beyond 6 months. And it looks like people still have some level of protection with the Pfizer and Moderna vaccines, which are the ones primarily used in the US, out through at least through 6 months. In fact, I think one of the drug company CEOs, the president of one of the companies said, yeah, I think we're going to need boosters at 6 months. And Dr. Fauci said, I don't think it's up to them. It is not up to them to decide when we get boosters. And so right now it's looking like at 6 months, there is still a significant level of protective antibodies. So what happens is, you get a shot and that your level of antibody starts to climb. You get a booster and it goes higher. And then it drops kind of quickly at first, and then it kind of levels off. And we're in the leveled off period, and it still looks like the levels of protection, we're assuming that it's this infection fighting protein called antibody, remain adequate at month 6 for the RNA vaccines. For the other vaccines, it's less clear. So for instance, with the Chinese vaccine, one of them, the one from a company called Sinopharm, which actually has pretty good efficacy. In some places, in the Middle East in particular, where they were using the Sinopharm vaccine, they've started to give 3rd doses of vaccine because they're worried about the levels of protection dropping. They're doing it, so I use the word empirically, but they're kind of making a best guess as to when the timing of it. And they're right now focusing on people whose level of protection might not have been high because they have other conditions that decrease your body's ability to respond to the vaccine. But I think that for some of these vaccines, we're not the ones in the US, but some of the other ones used around the world, people are really, really studying whether additional vaccination will be needed. And actually, this is now a segue into probably maybe something you were going to ask about. Can you mix and match vaccines? So some of the additional studies now are mixing and matching based on what a person got originally to see if the second type of vaccine or second vaccine gives you a much stronger response. And typically that's what we would expect, that if you went from the Chinese whole inactivated vaccine to the Johnson & Johnson vaccine, that you would see a really significant increase in the level of protection. And actually, now, not necessarily with COVID vaccines, but with some of the other vaccines that I've studied, like the HIV vaccines, sometimes that protection lasts for a much longer period of time, which is really would be a great thing. But it's too early to know now. So actually, to get to one of your points, Hawaii's got a pretty good level of vaccination, I mean, pretty similar to the rest of the United States. When you look at the United States and when you look at states within the United States, there are differences, sometimes really dramatic differences in the level of vaccination. If you look in California, and actually someone broke it down by Republican versus Democratic parts of California, it's not been published, but the Democratic parts of California really, really have high rates, in the 60 to 70% range, and some of the Republican parts are much lower. But that difference creates potential problems. And you can see the same thing in the United States. If there's a part of the United States that's high in terms of vaccination, and another part that's not high, although the overall rate for the United States is going down, and that's a good thing, this other group of people are potentially at risk, and they're potentially at risk in a way that, I think you remember during the surges of COVID in the United States, sometimes initially it was California and New York, and then they were spared as, some of the Midwestern states got hit. And then you saw it appear again in New York, California, Texas again. And so the virus goes from place to place, depending on, where uninfected people are and where risk is greatest. And right now with, the coast of the United States showing much higher rates of vaccination, and then other parts of the United States showing lower rates, you have the potential then for these large outbreaks in the areas that aren't vaccinated. And we know that these large outbreaks generate mutants, and mutants at some point, right now the mutants look like they're still sensitive to the vaccine. But when we have these large outbreaks, we're running the risk that mutants will be generated that at some point will not respond to the vaccine anymore. So it's really important for people to get vaccinated. For a state, it's really important to protect frontline workers, people exposed to the public, people exposed to people who are coming into the state of Hawaii from outside, who may or may not, respect all the rules. It's really important as the state's opening up to make sure that the vaccination is uniform across the population. And how does the state do that?
And we just had a pretty good sized cluster on the Big Island at the jail, and it was a large group of these inmates as well as employees have chosen not to be vaccinated, and they create this very large cluster. I said a little bit earlier about, like, if you look at the state of Hawaii and you say you're at 52%, there are segments of Hawaii that may be at 30%, and there are segments, some communities that may be at 70%. The 52 is an average. June 15, there will be no restrictions for travel inter-island, so anyone traveling inter-island will be able to fly without a test, without quarantine. And I think my concern was that there are still a lot of people that are not vaccinated that will be traveling. And I was kind of hoping to get your thoughts on that.
Yeah, and so I think it's important to recall from the days before we had the vaccine, right? That the reason to wear a mask is not only to protect yourself, but to protect others. And one of the things about Hawaii is the concern that you have for everybody, right? I mean, Hawaii is not necessarily unusual, because there are other states that are like that. But in Hawaii, we think about each other, and when we think about vaccination, you're protecting yourself. That's important, but you're really protecting other people, the people you're going to meet. And it's not only your family and friends, but it could be a person that happens to be eating in the same restaurant as you, or the person standing, in front of you in the line at the drugstore. So it's really about, us working together as a community to protect not only ourselves, but to protect everybody. And maybe by, what the state can do is it can find those areas where vaccination rates are low and come up with programs to really get people out there, make it easy for people to get vaccinated. And I think right now in Hawaii, it's probably pretty easy to get vaccinated. Put a positive social spin on it. People need to be able to talk about being vaccinated in a positive way. And so in part, this was why the CDC said, if you're vaccinated, you can take your mask off, because it creates an incentive. People want to be vaccinated. That's the last part. You have to make people want to get vaccinated. And as you see all these things, being able to take off your mask, being able to eat out, all of these things should be positive inducements to it. I just hope that in the outbreak on the Big Island that no one, got sent to the hospital and no one died. But we run that risk whenever we have a big outbreak. And that's a relatively closed setting. But imagine if, in states that have, where 70% of people aren't vaccinated, or countries where 99% of people aren't vaccinated, they are a tremendous risk. And these outbreaks will generate mutants. And we know that it will happen quickly because we've seen it happen this way before, that where we least expect it, sometimes when we're not paying attention, an outbreak starts and then starts to grow in the community. And once we find it, it's a full-blown problem. And then we're playing catch up, and that's difficult.
Let me ask you this. A question was posed, but again, kind of going back to what you said about the spreading of this virus. And you use the example like a choir, right? You need more air to belt out a note. So let's take, for instance, our children, because they are thinking about 100% opening up next school year. Vaccines is 12 and over, not 12 and under. And we have all of these young ones that are potential targets for the virus. That's if they don't come in contact. But should they come in contact with somebody that may have it? Because we've had cases here involving young ones. They have a tendency of playing out in a playground, yelling at the top of their lungs, doing all the kind of things that ripens the potential of spreading it. What can you say about that? You know, do you think that's and plus having a distance in schools of only 3 feet distance as opposed to 6 feet?
Yeah. So, so it's interesting that kids have been relatively spared, because we know that the behaviors that children have should theoretically put them at increased risk. On the other hand, there seems to be some level of protection, and one of the thoughts is that kids are commonly exposed to what we call, to other kinds of coronaviruses. So remember that COVID-19 is only one of a family of different coronaviruses, and some of them cause something much more like a common cold. The problem with these, your protective response to these cold, the circulating coronaviruses or seasonal coronaviruses is that your level of protection doesn't remain high for very long. But if you're exposed often enough, you may have some level of what we call cross protection. And it's thought that one of the reasons kids have been relatively spared may be that although their behaviors, which might make them at greater risk, they may have some level of protection from the other things that they've been exposed to, the other coronaviruses. Increasingly the vaccines will be de-escalated, and we say. We'll start testing them in younger and younger age groups in order to capture more and more of the potential population. And that's going to be important. It's going to be really important that teachers be vaccinated and that teenagers be vaccinated, because teenagers also, their behaviors that they do, the way they talk and group and eat and fool around, teenagers are at significant risk, not only for just acquiring infection, but importantly, spreading it to other people. We limit that if enough of the older part of the population are vaccinated. But as people have seen, just because your grandpa has gotten the Pfizer vaccine doesn't necessarily mean that they can't be infected. They can be. Hopefully that vaccine keeps them out of the hospital. But again, it's we really want to see no COVID hospitalizations and 0 COVID deaths in Hawaii or in the United States. And it's difficult. I mean, in Korea, I think every day now we have 2 to 3 deaths, which has been pretty constant. So, 3 to 500 infections, 3 to 700 infections a day, 2 to 3 deaths a day.
Okay. Yeah.
Yeah, no, it's that's the part that scares me. I mean, our average is in 3 a day, but we just lost 3. I think day before yesterday, another one a couple days prior. So the deaths are still happening here, and proportionately to the number of cases, it's relatively high versus Korea, who's having 300 a day to 500 cases a day and maybe 3 deaths. We're getting 30, 40, 50 cases a day. I don't know what the numbers are. I'd have to go get the numbers, but it seems like we're getting the proportionate or the proportion of deaths with the low number of cases is quite alarming.
Yeah, actually, I was talking to Debbie Burks about 3 weeks ago, and what she said was once vaccination started, we really decreased the amount of testing that we do in the United States. So that a part of it may be that you're only seeing the most severe cases being hospitalized or coming to attention and actually being tested. Whereas in Korea, there's, because they haven't deployed, 14% of the population's gotten at least 1 dose. So they're still doing a lot of testing. So they're probably capturing a much bigger population group of people. I mean, I guess Korea has 51 million people. 500 infections a day turns out. So if you think about it, I think of the number of infections per million population. In Korea, it's between 10 and 13 per million population. US was up in the 400s and has now come down and is under 100, which is really great. On the one hand, on the other hand, a lot of the people who are being infected now are younger because the older people have been vaccinated, are younger. And some of those young people are being hospitalized and some of them are dying. So again, the shifting age range is occurring because of the success of vaccination. And hopefully, the younger people will be vaccinated. I mean, it sounds like many universities are thinking about opening up also. Hopefully, and some of them are requiring vaccination.
Testing. So in Korea hasn't really changed the way they're handling COVID with testing, contact tracing. All of those things are still pretty much the same as it was the last time we spoke, right?
Yeah, actually, we had a case at our institute, and someone who was exposed from a housekeeper, and the person was the only one in the family who was infected. But I happened to be sitting in a meeting with that person, and we called up the local health authorities and the Center for Disease Control, and we got all these instructions. Well, it was 3 days since the exposure, who are the close contacts? And so I was identified as a close contact, although we wore masks and were, sitting across this table the whole time. And so I got tested and stayed home until my test result came back in the evening, and it was negative. So yeah, and then, we sent people home, we were enforcing, and then finally the building was disinfected. They sprayed this disinfectant all over the building, and by 2 days later they said, all clear, you guys are fine. No additional cases. All the contacts have been tested and are negative. And the person developed, so they take you first to an isolation, a place where you can stay, you can actually work, there's Wi-Fi, but you're isolated. And then if you develop a symptom, then you have to go to the hospital. So they had to go to the hospital with a fever, and then they keep you there, doing X-rays, and they're monitoring the amount of oxygen in your blood, and so they're still doing that. I think the idea is that it's fine to tell a person that they need to stay inside, but there's no guarantee that they're going to stay inside. In fact, there have been some people who've been caught outside. So they started this residential isolation program. And then actually you're monitored. So if you have problems, then they send you immediately to the hospital where you're put in isolation. So in the hospital isolation. Interestingly, sometimes the hospital isolation are people who are infected, but 4 people in a room. But there, I think the thinking is that everyone's infected, everyone's being monitored, and anyway, I think private rooms are kind of not uncommon in Korea, but they're less common than in the United States.
One last question, Doc. And I know you answered this before, but if someone a year ago had caught COVID, and now you say if they get vaccinated, they're basically within their system, they should be at a higher level of fighting it if it ever should come back to attack them, correct? So
Correct.
I guess my question to that is, at what point in time do we know, and I know you touched on it, trying to find a way of quantifying the effectiveness that stays within your body. But when Mel posed the question based on time, does the person's medical condition, like the pre-existing condition, what makes them a candidate for the least amount of immune responses, all of that, does that play a role? Because I would think that would cut the time down as far as how effective if you were to get vaccinated. The length of time it would stay within the body, right? If that person has all these other compromising situations, wouldn't that be it?
Yeah, that's exactly the case. So, your body's defensive system, your immune system, is pretty strong and robust. But, just in general, as you age, but also if you have certain medical conditions. The immune response can be less strong. So diabetes would be a fairly common example. But then also if you're on chemotherapy, or if you're taking a drug that decreases your body's ability to respond to infection, or something that is supposed to control. So some people have particular kinds of arthritis, like rheumatoid arthritis, and they have to be on medicines that suppress the body's immune system to keep the body from making the arthritis worse. And medicines like that can actually impair your ability to respond to the vaccine. And it's kind of interesting. So the Johnson & Johnson vaccine, which again, the Novavax vaccine, which hasn't been approved yet, but hopefully will be approved in July, was tested in South Africa against the South African variant, and efficacy was under 50%. When they removed the HIV infected people who had lower responses, the efficacy went up to above 50%. I mean, it wasn't a lot of movement, but it gets to the idea that there are certain conditions, and the acquired immune deficiency syndrome, or the human immunodeficiency virus, is one of those things that can impact the body's ability to defend itself. Now, if a person has been treated with antiretroviral therapy, for instance, their body's immune system is largely going to respond as it should. But again, it's really important to emphasize that there are both there are conditions, there are medicines, and there are other non-immunological conditions like diabetes that can really impact the body's ability to generate the correct protective response. And I guess the last thing, remember, we were talking about if you're infected, and if you've been infected with COVID and you are vaccinated. And one of the questions is, do people need 2 doses, or can they get away with 1 dose? And we don't know the answer to that question, but the response to the first dose was so great. Again, I think this is something that we continue to watch and look at and try to figure out what the optimal regimens are. I mean, I think I may have said this on the first show, but one of the things is we didn't cut any corners. But what the government did with Operation Warp Speed, and something it did really well, was it told the companies, make up your best guess as to what will protect people, and tell us the experimental design, and we'll approve it. And if at the end of the day you show protection with 1 dose at time 0, 1 dose at 21 days, then we'll give you emergency use authorization. And that was great because the companies rapidly found what they thought was the right dose and the right dosing regimen, and they went with it. And at the end of the day, scientifically, it did what it was supposed to do. But now it might be important to say, well, if you give a dose now and a dose at 12 weeks, do you get a better response? Does it last longer? Do you get a much higher response after the second dose than you did when it was only a month apart? And we're starting to see some of those data appear. And for a vaccine like AstraZeneca, which isn't used in the United States yet, spacing it out to 12 weeks actually makes the response a lot stronger. Gives you actually a much higher level of protection. It was 60% originally with 2 doses 1 month apart. It was 80% if you spaced it out to 12 weeks. So, and actually that makes sense. Why would we give it 2 doses 1 month apart? Well, if you're in the middle of a really bad outbreak, you want as much protection there as quickly as possible. And for some of the vaccines, you need the second dose, particularly against the variant. So you want to move the dose together. So again, there are some things about the way we respond and the situation that may change the way you give the vaccine. But of course, the US doesn't use AstraZeneca, so not a big concern.
Wow.
And it seems like forever, but it's still relatively a new virus. We're still learning every single day. And geez, our hour went by really quick. I just want to give you an opportunity to share with our viewers. Hawaii should be at 70% in a month or so, probably before the 4th of July weekend. At that point, our Safe Travels program will be ended, and people will be free to fly.
In and out.
Without any testing. I think that makes it even more important now to focus on the masks and the social distancing. But any closing thoughts for our viewers here in Hawaii, Doc?
Yeah, the vaccines are safe and efficacious. And, we know that as more and more people are vaccinated, that we're approaching levels of what we call herd protection. And it may not be 70%, it may be 80% or 85%, and it differs for each vaccine. So if you know of people, friends and family, or coworkers who aren't vaccinated, you really need to get them out there, and you need to get them and talk to them about the importance of us all being vaccinated, because we're not only protecting ourselves, but we're protecting everyone that we work with and live with or love. And it's really, really critical that if we're going to get control of this, that we do this together.
Awesome. Charlie?
Well, as always, I like to say thank you to our esteemed guests. We are so fortunate to have him on, Dr. Kim. Thank you so much for joining us today. And to our viewers, Nella and I, former law enforcement, I was thinking about, sometimes people have this question whether I should get vaccinated or not. And the only way I can think of it is this: if you live in a neighborhood that has gunfire all the time, and you might be living behind a wall that's protected, I would say just wear a bulletproof vest, even if you don't have to, because you'll never know if that stray bullet will come for you. At least you'll be protected. Okay. So I equate that to this vaccine. You don't want to take it, that's up to you, but you'll never know when you'll come in contact. And hopefully, if you do come in contact with a sneaky little virus, you'll have something to protect you, at least get you over that hurdle so you don't have to end up in the hospital. So again, there's a lot of people out there for medical reasons that can't get vaccinated. But for those of you who are still sitting on the fence, I urge you to consider it, because, this virus is like a model airplane with no rudder. It's just flying up there, and wherever it lands, it'll land. And you just don't want to be in that area where it lands. Okay? That's to all of our friends out there. Thank you very much, Mel.
Thanks, Charlie. Thanks, Doc. Again, appreciate your time. I know you're a busy guy. Guys, you guys can catch Dr. Jerome Kim on his Facebook page. Go follow him and get him straight from the horse's mouth. Again, appreciate and hoping that you get to come back home this month in a week or so and enjoy Hawaii a little bit. Just want to say, people, Hawaii now, if you get vaccinated, whether you have or you're going to get vaccinated, they're giving away all kinds of prizes. Go to the website. I think it's hightgotvaccinated.com or whatever. Put in your name and email. You might win a trip to Vegas, whatever. Go take advantage of that. Get vaccinated. Let's do it and keep our place safe as we head towards opening up our state. I'm concerned, but I think we can do that if we all pay attention and be smart. Dr. Kim, give our love to the family and stay safe up in South Korea. And when this is all done, Charlie's hosting a huge party. I know we've told you this before. And we want you and your family to be our special guests, honored guests. And so you can meet all of our viewers and we can thank you face to face. All right, Doc?
Love to do that. Stay safe.
Right. Take
Thanks,
care.
Mel.
God bless. We'll see you soon, Doc. Aloha.
Aloha.
Hello.